Hello and welcome. I'm Dr. Yodi Alakija, and I am going to be your moderator for this session. You can already see on the screen what my various designations and titles are, so there's no need to go into that. We have a lot to do in this session. We have an exciting session ahead of us. And as we go ahead, I'm going to be introducing my colleagues and friends as they begin to speak. But for now, I'm going to give a few opening remarks about this vaccine hesitancy and uptake session here at the AIC 2021 virtual conference. As the world races against time in a bid to outrun the coronavirus, COVID-19, it appears the race has staggered in favor of the wealthy nations and the wealthiest people from the world's poorest countries. The media is currently awash with images of world leaders, health workers, and vulnerable people getting that long-awaited vaccine jab in their arms. Social proof campaigns like V for Vaccinate encourage people to rush out and get vaccinated. Yet for many of the world's poorest people, there are no vaccines in the immediate future. And similar images from many parts of Africa and Southeast Asia could be quite a while away. We're beginning to see a trickle of vaccines into the African continent, thanks to the COVAX initiative. And we have representing that initiative here, my colleague Tabani, who I'm sure will tell us a bit about it. Countries like Nigeria, Ghana, many countries, I believe Kenya, a few others have received vaccines in the last few days. I think about 10 countries so far, but Tabani will correct me if I'm wrong. So we're beginning to see a trickle. But for Nigeria, for instance, Nigeria has received 3.92 million vaccines for a population of over 210 million people. But yet we know that in America, they're now beginning to vaccinate 3 million people per day. So where is the equity in that? We're talking about vaccines and we're talking about uptake and access in this session. But should we, first of all, we need to actually have vaccines. We need to have the conversation about equity. We need to say the vaccines for all needs to be the mantra. And yes, until we are all safe, none of us can be safe. Last week, I chaired a meeting in which we had Dr. Tedros, the Director General of the WHO, state very clearly that the world really needs to wake up and make sure that we can get vaccines to some of the world's poorest nations so that we don't have this issue of virulence and mutations beginning to affect us. The EU Commissioner in the same meeting, Jutta Urpilainen, talked very strongly about the fact that we're in a race against the virus, not a race against each other. And until we are all safe again, nobody can be safe. We had Professor Peter Piot talk about the reminiscence between this and the days of the HIV/AIDS phenomenon across the world. So we have colleagues who are working in that space right now who will also speak about that. The equity issue of those times was that Africa was last. Africa was left behind. Africa did not get the medicines needed to save the millions of lives that could have been saved had we had the proper access. Today, we have the similar issue. A couple of days ago, I gave an address at the London School of Hygiene and Tropical Medicine where I said that the vaccine equity issue is the HIV/AIDS of our generation. It is the HIV/AIDS of our time. And without dealing with this, we are not going to get any further with this virus. We're already beginning to see people name variants. The South Africa variant, they call it. Soon we will have the Lagos variant, we will have maybe the Uganda variant, the Abuja variant, because until we get vaccinated, there are going to be variants all over the place. So how about we first of all shout out for equity, vaccine equity all over the world, and then begin to talk about how we ensure that people are able to say, yes, there's a vaccine available, but maybe I don't want to take it, or I do want to take it, as we spoke earlier. Without further ado, I'm going to head into the panel and introduce you to our first panelist. Our first panelist will be speaking from a perspective of, I guess, Ethel, what are you specifically talking about today? We're going to make this interactive. We're going to make it fun. It's not going to be fussy. So Ethel will basically, I mean, I'm supposed to ask Ethel a question. Ethel's the Associate Director, Advocacy, Policy and Communications for the International AIDS Vaccine Initiative. And so I've already spoken about how this is reminiscent of HIV/AIDS back in the day. I was telling my co-panelists earlier that I'm only 35, but I also remember when HIV was a major global issue and when we were all fighting for HIV drugs for Africa. So how do you feel about this, and since you work in that space? And also, what do you think causes hesitancy and poor uptake of vaccines? Over to you, Ethel.
So thank you. First of all, I'd really like to apologize to all our participants that I'm unable to have my video on. But just as you say, I would really like to look at the issue of access to the vaccine. The equity in access to the vaccine is really is a critical issue. And just like you, I'd like the opportunity to have the vaccine here and say, yes, I want to have the vaccine. Talking about hesitancy, what causes hesitancy? You know, about 10 years ago, my daughter came back from primary school, and she had this note that telling me, basically informing me that there'll be somebody at her school the next day with a vaccine, and that she was going to be vaccinated, and they needed my consent for this to happen. I did not know the source of the information. I had not met these people before. I did not even have a sense of the risk, what disease is being vaccinated against, and whether or not my child was really at risk. And then also there was the issue of money. I was being asked to pay around about $15 for the vaccine. So clearly, already you can hear I had my doubts about several things. You can see from my experience, I was hesitant. And really, vaccine hesitancy is that state at which I was in between delaying a decision to have my child vaccinated and actually eventually refusing to have my child vaccinated. And there are trust issues around when it comes to hesitancy. It could be trust, a lack of trust in the person or the institution that's administering the drug, the origins of the vaccine. It could even be the administration, my government, my leadership. Do I trust them? Do I trust the policies that they've put in place? Or like I said, the perception of risk. I was not sure I felt my child was at risk enough for me to rush and have the vaccine administered to her. There's also perhaps the idea or the perceived or real inconvenience. I was being asked for money that I did not have at that time. There could be other issues around the inconvenience. It could be not just money, it could be access, the distance, the time I'd have to take. And also there's the real issue of beliefs and values. How are my beliefs, how my religious beliefs being affected? Or how are the beliefs that I have based on somebody I trust or look up to a leader, a thought leader? How is this, being affected? So really, vaccine hesitancy has lots of faces. It's not homogeneous. Even within one geography, you can find all the variants. Let me use that word, the variants of these issues around hesitancy.
Thank you very much, Ethel. I'm going to pick up a point you made there. Thank you. And I'm going to come to you, of course, with more questions later. But I'm going to head straight to Thabani, who's the Managing Director, Country Programs for Gavi. And Thabani's joining us from Geneva today. And I'm going to flip your questions on the head and refer to something I said in my opening remarks, and said that we've seen the arrival of vaccines in a few African countries funded through the amazing COVAX. And as Gavi discusses the strategies for COVID-19 response, what are you guys talking about with regards to uptake, demand creation? I mean, I'm very well aware that that's not your job. COVAX sort of ends at the port technically, but I mean, surely there must be in-house discussions, and perhaps you can tell us a little bit about, how many countries have received vaccines and how many more are coming, fingers crossed, in the not too distant future. Over to you, Thabani.
Thank you so much, and thank you for having me. I think that I'll begin by probably saying that it is absolutely our job to make sure that the vaccines are demanded and they are needed, because the biggest risk here that one can ever sit with is to get the vaccines to the port of Mombasa, and you have them wasting at the port. That would be the greatest loss for us. So it is absolutely our job that the vaccine from the manufacturer to the patient actually reaches where it is intended to reach. But I'll talk about that a little bit more later. But let me respond to your broader question. The last 2 weeks have been exciting weeks for COVAX. Seeing those vaccines hitting the shores of Ghana, Cote d'Ivoire, and Nigeria, Kenya, DRC, it has just been fascinating. And you can also see that when we talk about just the heterogeneity of demand, the level of excitement that we have seen in those countries, it gives me hope as well in terms of vaccines will be arriving soon. So at this particular point, vaccines have arrived in 22 African countries, and 14.7 million vaccines have arrived. But the biggest challenge, and you really speak about equity here, and you started by talking about inter-country equity. My number one worry now is actually the intra-country equity. Are the vaccines going to get to the right people when they get to countries, or are we going to have some elitism associated with these vaccines? And what does that then mean? So for us, it's equity up to the end, up to the patient themselves. Are we identifying the populations correct? And are we preparing them to make sure that, that they are ready? So that's what I can say in a nutshell. We are interested in demand, but we are also interested in equity to the last point.
That's a great point you raise, Thabani. Thank you very much. I'm also very concerned about equity within countries. And I take very well your point that you are concerned about, obviously, that it is your job for uptake and hesitancy, because we have to get vaccines. My newest saying, which I'm now going to trademark, is ports to arms, quote unquote. That we need to get vaccines from ports to arms. And as you saw earlier, I co-chair the Africa Union, AVDA, Africa Vaccine Delivery Initiative, which is very much about getting vaccines from ports to arms. So I agree with you there. The other thing that I think is very important in what you're saying, two things actually, and well, it's all important, but the things that jumped out at me. One was, you've said that there's been excitement as these vaccines have arrived, which we're all beginning to see. And I think we're beginning to, we thought there would be greater hesitancy than there was, but there seems to be that almost the scarcity has almost, in a way, it's generated a demand that everybody is like, well, I want to get one, I want to get one. And it goes to your second point, where you said that there's also inequity within countries, intra-country equity. And in my opening statement, you'd have heard me say that the race is staggered in favor of the wealthy nations and the wealthiest people from the world's poorest countries. Because, there's some countries, my country, Nigeria, for one, where we're seeing that people are being asked to register online via an app for vaccines. So that tells me that our 3.92 million vaccines, if you need to register via an app, is definitely going to go to the 1% of the 1%. Because even me, Ayade Morenike, I don't know how to register via an app. So I can't imagine how people in more rural communities and areas are going to have to deal with that. So I would like us to park that and to sort of think about that. As I really, move on, and I'm going to come back to you in a bit, Thabani, about, the work that's still to be done. But for now, I want to go to my brother Taj. Raji Tajuddin is the head division of public health institutes and research for Africa CDC. And Taj has been working on a few studies with Africa CDC on public knowledge and perceptions on the pandemic and on the vaccine. And I know that I was just saying to him that I've been advising in the background with the London School of Hygiene and Tropical Medicine on one of these studies. So what would you say, Raj? Where are you with that, and what are we seeing?
Thank you, Madam Chair, for the opportunity. Let me first and foremost begin by thanking the organizers of this important meeting. That's Gavi and the other partners that put this together. And this particular session for me is also quite timely because we are just beginning to see vaccines roll out on the continent. So there are some key findings from this survey that we did from August till December late last year. This was a survey that was done between Africa CDC and the London School of Hygiene and Tropical Medicine. In terms of uptake, let me say that 4 out of 5, of the respondents from the 15 countries that we surveyed were actually ready to take this vaccine, which is in sharp contrast to what we are seeing in the West, especially Europe and the America. But having said that, again, even within Africa, we have regional differences. For instance, in places like Ethiopia, Tunisia, and Niger, the uptake is as high as 92 to 95%. Whereas for some countries like DR Congo and Senegal, the uptake is something around 50%. In fact, in DR Congo, it's actually less than 60%. So that's one thing. The other thing is quite a majority of the respondents actually believe that this vaccine is important. They believe that it's quite effective. However, safety is their major concern. Safety remains a major concern for them. In fact, 1 out of the 4 that are going to be hesitant as far as the vaccine is concerned actually underscore safety as their main reason for not taking this vaccine, around 60% or so. For the other people, it's mainly lack of trust, the fact that they needed more information, the fact that they've never seen anybody with COVID-19 before, the fact that they also believe that there's some conspiracy around the COVID-19, and then much more importantly, again, they believe that is all scam from certain countries. So, and unless we try and address some of these issues, there's no way we'll be able to make progress in terms of creating demand within the population. Another very key finding as far as this survey is concerned is the fact that, just to speak to what Tebani is talking about, the issue of prioritization. About 1 in 4 does not believe that there is need for any prioritization. They believe that this vaccine should be rolled out for everybody. You should all go and get it, so which is also a major concern. So I think in the spirit of fair allocation and fair and equity, I think there's also need for some sort of communication and the framing of public health messaging around issues of uptake. Issues of prioritization. Then in terms of who give seal of approval before the populace will take this shot, again, quite a lot of the respondents believe that if the healthcare workers, if the government, if WHO, if Africa CDC can give them the assurance that these vaccines are effective, they are safe, they are more than glad, to take up this vaccine. Again, which underscored the importance of healthcare workers, the importance of the government, trying to make sure that they appropriately frame this message and also use it to get the demand created within the community. And last but not the least, Madam Chair, before I hand over to you, in terms of trusted source of information, more than 60% of our population actually believe that if they get the information from the healthcare workers, from the government, surely they will go ahead. Some also believe that TV, radio, and so on and so forth. Again, this also varies from one part of the continent to the other. So the emphasis here is we need to also as much as possible, locally contextualize the way we pass out this message. For instance, in West Africa, radio is the most trusted source. So meaning that we need to work with those media within that space of radio stations. You know, whereas for up north, they believe generally that healthcare workers are their own trusted source of information. So meaning that we need to work closely with all these groups. So thank you, Madam Chair. Let me hand over to you at this point. Over.
Thank you very much. My brother Taj, you've raised a couple of issues that I want to pick up on just for, I mean, I know there's a really robust conversation going on in the chat box. So do note that we're looking at that. But I'm sort of picking up off some of what I'm seeing. You've raised the issue of trust, as did Ethel at the very beginning. And I think trust in government and trust in institutions are sort of the key things that we need to be keeping an eye on when it comes to vaccine hesitancy. You've also raised the issue of equity. One thing you've talked about from the survey, and I know that I raised this when I was asked to advise on it with the London School, is that the survey numbers seem really high. I mean, very, very, very optimistic indeed, almost overly so. I know the sample size, of course, was small, and I think we should always mention that, you know, that the sample size was relatively small per country. And it was done across, also to clarify, it was done across 16 countries in the Africa region. But 90 to 95% is huge. 50% in DRC sort of seems to more fit in, but of course DRC, because of Ebola, the Ebola vaccine, and what has gone on there, there's a lot more sort of, I guess, skepticism. So those are some areas to sort of take into account. I just wanted to touch on those before moving on. But I think you've laid things very, very nicely for Dr. Joy, when you talk about, you know, the fact that some countries trust healthcare workers more than they trust others. Some want radio jingles. I mean, I think that's a whole nother webinar topic for us to have, because somebody has said in the chat, and I've just written this down, Rodriguez has said, yes, African countries are ready to receive the vaccine, but are the African populations prepared to receive the vaccine? And I think there hasn't really been enough work done in that regard. So I'm going to move over to Dr. Joy Mugambi, who's the Honorable Secretary General of World Organization of Family Doctors, Africa Region. And Dr. Joy, you're also the Vice President, East Central South Africa Commonwealth Medical Association, and you're a family physician, so you know exactly what you're talking about here. And first of all, I'm going to go to the fact that combating vaccine hesitancy needs to be a community undertaking as much as a national undertaking. And I think for me, that is one of the gaps that I'm beginning to see now. There's been a lot of focus on, you know, getting the vaccines, but have we prepared our populations for, as Rodriguez said in the chat. So how do we build structures within communities? How do your network of doctors and family physicians, how do they augment what's going on? How do they lead? And also, how do they, you know, build on the existing healthcare worker system? Do we need volunteers? What do we need to do in Africa for us to get deal with the perceptions? But I think, quite frankly, also, as we're seeing around the world, how do we get people vaccinated? We're not going to be able to roll out from ports to arms if we don't build a much greater force of vaccinators. What would you say to that, Dr. Joy?
Thank you very much, Alakije, and the team. I'm very grateful for Raj for having opened up this conversation, because for once, I would say COVID brought in the idea that primary healthcare really needs strengthening all over the world, and especially in Africa, because we really had a poor primary healthcare system. And looking at where I am, yes, we do need a strengthened primary healthcare. When you look at the primary healthcare aspect, the first person who sees that client when they get sick, which is the larger population that lives in rural areas, is a primary healthcare provider. And where there is a family physician, it is a family physician. They've built trust. They offer continuity of care. They're comprehensive. And they have had this relationship with communities. So in order for us to mitigate the hesitance that's there in communities, we really need to engage communities at the very community level, because when you get ill, the first person you inform is the person living in your household. The household person will probably call a pastor or an imam or a religious person to pray for you. Then next, you probably will look for a healthcare practitioner. So there is a whole system below the healthcare practitioner that really needs to be enhanced and informed in terms of the vaccination processes, the safety of the vaccine, and so much in terms of the vaccine in order for acceptance to be achieved within the communities. So for us to have efficacy when it comes to uptake, when it comes to hesitance, we need to engage communities. And this has been one of my key strengths where I'm working, engaging with the communities where I am. Before I enter into the community, I do speak with the elders in that community, the religious leaders. We have a monthly meeting where we do meet. We engage, we highlight issues that are affecting the community. And part of it is what we are talking about right now is the vaccination processes, the challenges, what they are encountering in the community. But most important, we need community health workers, the community health volunteers. Strengthening that part of our community is really, really important because these have been key people. We have programs in TB where we work with community health workers. My community health worker is so key. By the time I get that patient diagnosed in the facility, I link her with the clients, and within a short time, she's linked me with contacts. And we end up getting in touch with the community in a much easier way. So even vaccination can follow the same pathway.
Thank you very much, Dr. Joy. You've really pulled in some of what we're already seeing in the chat about the involvement of community health workers and the involvement of building trust within communities and building, trust in the vaccine, basically coming from the medical or the volunteer community. I know there's an incredible community. I think I referenced this the other day when I was speaking, that there's an incredible community health choose system in Ethiopia that I've visited, where down to the very smallest unit of the community, the community health worker, often just a volunteer, not very often literate, most often a woman. Happy International Women's Day, everybody, a couple of days late, is typically, the most trusted person in that community. And we have to ensure that if they are, if they are trained and they are made to understand the importance of these vaccines, we can definitely start to get them from ports to arms. So I'm going to move on from you, Dr. Joy, to Maysoon Lulu, who's the Regional Director of Vaccines Policy, Eastern Europe, Middle East, and Africa for MSD. And Maysoon is going to first of all tell us, because she's the only one on this panel who has received her vaccine, which we learned earlier. So you're vaccinated. Congratulations on that. And I'd first of all like you to talk about that, which of course is a geographical, this is a whole geographical phenomenon we have now going on. So clearly when everyone hears where you live, they'll understand why you've been vaccinated. And then I'm going to have you speak to, a little bit about what is how do you think we should approach the situation of rebuilding credibility and trust, and a word we're hearing all the time, and how can the private sector help? Maysoon, over to you. Maysoon Lulu.
Thanks, Dr. Alakija, and thank you for having me on this distinguished panel. Yes, I have received 2 doses of the vaccine, and I part of this panel, of course, this is very important to address that, and I'm glad to see that we've already heard that a lot of doses are making their way to Africa, because this is where how we can achieve equitable access to vaccines and to the people who really need them. Going to your question about how can we re-achieve this? Well, certainly building and maintaining vaccine confidence and creating resilient vaccine ecosystems requires a multi-pronged approach. We've seen that, over the last period, there's a lot of miscommunication sometimes between health officials, government as a result of the pandemic, and it's been exacerbated with the situation. So to address vaccine hesitancy, we need a coordinated, collaborative approach to ensure that all our stakeholders are connected and aligned with clear, consistent public messaging. We've seen in the past where concerted efforts to address a global issue can be successful, like HIV, cancer, Ebola, and many other global health challenges, which have made huge advances as a result of collaboration. And I strongly believe that working together as a community with aligned stakeholders, we too can be successful in rebuilding confidence in vaccination. In my opinion, the current challenges will require us to think creatively, as we have heard from Dr. Joy and Raj, to think creatively on who the influencers are. We know, for example, that trust in community leaders and employers and healthcare professionals is high. So we need to consider how to work with them to ensure they provide connect information to the public who trust them. As for the second part of your question about the role of the private sector, as a company, we're responsible for ensuring the safety and efficacy of our vaccines. As we've heard, these are primary concerns for the public. So we, as a company, commit to ensuring we have safe and efficacious vaccines. But we also know that our role as a private sector does not stop with our products. We are part of the vaccine community, and we need to be acknowledged as part of the vaccine ecosystem. And thus, it's important for us to understand issues behind vaccine hesitancy. And because when there's no confidence in the system, then our vaccines won't get to the people that actually need them. As a pharma industry, I can insist that we continue providing safe and effective vaccines, as well as support awareness activities, research to provide evidence-based solutions. With our experience with the HPV vaccine and the increased hesitancy towards it, we learned why it's very important to engage with healthcare professionals and governments to understand the value of vaccination. So we worked with government and key stakeholders to build capacity around vaccine hesitance and help with plans to address the challenges African countries are having and how to manage them to ensure systems are sustainable and the ecosystem for vaccination is resilient.
Thank you very much, Mayloon. I'm going to pick up I'm going to come back to you on some of what you've just said from a private sector perspective, but I want to pick up on what you just said about working with governments and making sure, African governments, to make sure vaccines are safe, their populations can get vaccines, because we're seeing in the chat, some conversation in the chat about people saying that, well, we need to be, Africa needs to be part of the solution, not just the problem. We need to participate in the production of vaccines. I mean, this manufacturing question is really beginning to come up quite a bit, and I know that Africa CDC, Dr. John announced at the summit I chaired last week that Africa CDC will be hosting a summit, or the Africa Union will be hosting a manufacturing summit on April 12th. With the high-level political leaders around this. And we managed to get last week quite a bit of support from the Norwegian Minister for International Development, from the European Union towards this initiative. So we're happy about that. But the issue is that if we start manufacturing now, we'll be ready for the next pandemic. We're not going to be ready for next month or even, the next 6 months. We will be ready for the next pandemic. So yes, we do need to start thinking today about tomorrow, but it's important to bear in mind, it's coming up a lot in the chat, that, well, we need to be producing, but you can't just wake up and go and produce vaccines tomorrow. I mean, J&J, who are working with Moderna at the moment to retrofit their factory to produce vaccines, that with all of the might of America's money is taking a few months. So for us to begin manufacturing, but we need to start to have the conversation. So I'm glad that, companies such as yourselves are at the table. We need to start to have the conversation that, Senegal, Institut Pasteur in Senegal, for instance, who already are making yellow fever vaccines, how can they be supported to scale up their production? How can we have solutions on the continent and not just be seen as a problematic area? I'm going to go to Ethel. really quickly, because you also spoke about research. Tabani, I'm coming straight to you on this manufacturing issue. I know it's not one of the prescribed questions, but I'm sort of giving you a 2-minute heads up about what we can do about that, just thoughts. But for Ethel, what can the research community learn from this process with regards to trust building? You know, Maysoon has just spoken about pharma companies working with countries and communities. What would you say research community can learn from this, and what can we do differently? I also want to put a proviso there. This miracle of modern science, research, innovation brought these vaccines at incredible speed. So, and we want to say thank you for that. So we want to acknowledge that at the same time, but say, well, what can we do differently? Over to you, Ethel.
You know, I have listened to your reflections on Africa, and your reflections and actually your responses to what is coming up in the chat on Africa being a part of the solution and not just being seen as a problem. And what it brings to mind are the sentiments that I think we seemed to have collectively as a continent that may have a bearing on vaccine acceptance and uptake. I'm thinking about the outrage that was sparked by the two French doctors at the start of the COVID pandemic. That's one thing we have seen, that the COVID vaccines should be tested in Africa because the continent lacks resources to defend against COVID-19. And the ensuing conversations, which I can see are still being replicated in the chat, centered around whether or not vaccines originating from research that's developed off the continent can or should be trusted. And for me, this speaks to the need for Africa to have a sense of ownership of research. So you're asking about what we are learning. We are learning strongly that we need to have Africa's science leadership in product development that is contextually relevant. And I feel that this would also contribute towards the trust of the output of research, so that if we as Africans are seeing our African researchers leading vaccine developments, leading clinical trials, and even having the manufacturing being done on the continent, it may help to address the concern that Africa is seen as guinea pigs or test subjects by the global north. And for this to happen, it is imperative that our governments put more resources into health research and development. They have already made a commitment towards this. And so really it's time to put this into practice. Another whole area that we are seeing that is really different from here, I'm going to take us on a different tangent, is the whole idea of misinformation, disinformation. I mean, we have experienced what is being called an infodemic, and the ability to, an infodemic, and the pervasiveness of social media has made it that much easier to spread misinformation and rumors. Now, while I know I'd really like to take down some of those rumors, delete that misinformation, that is not possible. So perhaps as the research community, what we should really be thinking of is how can we use these rumors to understand what it is that is important to communities and start to address those issues, rather than hope the rumors will go away or that we can make people change their minds about certain myths that they hold very strongly.
Thank you, Ethel. How can we use rumors to understand what is important to communities? I like that. I will also say, I also see some of these rumors. In fact, I think I stopped using certain social media because I was getting some of it was so fantastical. The chips in bodies and something is going to grow out of your head and all the different things that were beginning to come up, and I think that, it's not, so I have to say that I don't know whether that is so much what is important to communities as much as the fact that we have so much available at our fingertips these days in terms of information. And there are also some, we also, I think we have to we have to acknowledge the fact that there are those who are deliberately going out to put out this sort of, actually quite damaging information to public health, not just the COVID vaccine. You've also spoken about research. I'm going to talk very briefly. Somebody's just said in the chat that we need research and development funded by African countries that will tackle the reasons for hesitancy and increase uptake. And this is somebody who works at the Israel Economic Mission, who wants to strengthen this sector. And that is really important. And I was having a conversation with somebody from Merck the other day, somebody very senior in Merck the other day, where we were saying that, if only some of the aid money that's coming to the continent, and Gavi might want to speak into this as well, just touch base on it. If only this could go into research and development to help us to help ourselves, teach a man to fish thing, as opposed to giving us the money to, or buying the product or sending us a product, perhaps help invest in that developmental phase and also help buffer the initial hit that we're going to take. Because if we produce and manufacture vaccines on the continent, for instance, back to R&D, it'll be more expensive. But if the donors can support that hit, perhaps it'll be better of better long-term benefits to the continent. I'm going to Tabani now, and I had given you a little bit of a heads up earlier. So if you could just address very quickly, from a Gavi perspective, just a couple of things, but I would also, obviously the main question I'm supposed to be talking to you about right now is that how do we ensure also that the hesitancy and these conspiracy theories don't spill over into regular immunization programs. So I'm just going to let you eloquently wrap it all up in a couple of minutes.
Thank you so much. I just love the energy in this platform. It's absolutely contagious. Let me respond to that specific question around manufacturing. And, as I was thinking in the 2 minutes that you gave me, I asked myself, or the first question I said was, if vaccine manufacturing is not discussed now, then when? Because if not now, then when can it ever be discussed? And my other argument here is, we cannot afford to waste a crisis.
Yes.
This is a crisis that we cannot waste. We must actually play into it in accelerating this. But there are a number of things that obviously you as the panelist and Taj here are very much aware of. But the Africa Union and the Africa CDC in particular have done amazing things in terms of, let's think about the PPE platform that was set up at the beginning of this crisis, how pivotal and how important it was to actually respond to supply constraints that we were seeing by pulling demand in the African space. The Africa Vaccine Access Task Force and its work. I think as an African, I've never been so proud of the moment where we are as a continent, where we rise and we take an opportunity to say we are ready to lead and we are ready to step in. And I think the AU has really shown a significant element of that. And so my argument or the long and short of my bit here is that if not now, then when? And if we cannot build the momentum on the back of this crisis, I don't know when we can ever build it again. And so that's a very important discussion for us to have. But I also really appreciated your framing on the other end. We should be pragmatic as we look at these things. The fact that we believe that vaccine manufacturing is an important part of the toolbox in Africa does not mean that it is going to happen tomorrow as well. So we've got to actually have a sense of realism as we approach this. But I think that we cannot waste this crisis. That would be my message in that regard. Coming to the other question that you asked me, which is quite a broader and important question for me, is Ken, if you can just mute yourself, thank you so much. I think we are concerned about the spillover effects of vaccine hesitancy that could come out of the COVAX space. But if I have to look at it in a more neutral way, I would also argue that there is also an opportunity here. I'm an eternal optimist. Never have we been in a period and a season where vaccines have been in everybody's mouth. My father and my grandmother approaching their 90s and their 80s, they speak about vaccines and they say to me, should we take this? And the bottom line is I have an opportunity to influence in my family and in my space. But I think it goes back to the fundamental issue of trust. Who do we trust, and who is going to spread the message that is needed here? And we should not miss the family level conversations. We should not miss the community level conversations. We should not miss the healthcare ecosystem conversations, the government conversations. All I'm saying is it takes a village to vaccinate a child. It takes a village to actually vaccinate people with COVID. So let's make sure that we are tapping to all those levels and layers. There is an opportunity. Vaccines are better known now than they were before. And let's use this opportunity to actually accelerate the use of vaccines as a public health good.
Thanks, Tabani. I actually have another question for you. That's really good. I mean, I hear what you're saying about vaccines being in everybody's mouth. I mean, my dear friend and sister, Professor Heidi Larson, I call her the vaccine queen because, you know, she wrote a book not knowing that this was going to happen, that she published this year, Stuck. And all of a sudden, it's all everybody wants to talk about. And it's a moment in time. And I agree with you, we mustn't lose that moment. It's an urgent moment. But we're here, I'm being reminded that part of the trust issue is people are saying, can we trust all donor-provided aid? What is the quality assurance and credibility of these vaccines? Can we trust these vaccines? That is part of what people want to know.
I'm so glad that you asked me that question. I may not have answered it. So having it directly answered that way is extremely helpful. We have Maison here. She spoke about how they think and approach it from a private sector perspective. But I can speak about this in terms of how we approach it from a COVAX perspective. As COVAX, our argument is that vaccines must be safe, they must be efficacious, and they must also be reasonably affordable. And all those three levers are quite important for us. But we have also a very independent mechanism that actually allows us to say a vaccine is safe. We could not have distributed vaccines until WHO independently could actually give an emergency use authorization. And so in my view, we have the right checks and balances. And the truth is actually your question that you just asked previously. It becomes quite an important question here in that if we are going to throw caution to the wind and send any vaccines that cause any harm at this particular point, we are reversing the gains that we have made in the last 20 years. So we cannot afford to lose trust that has been built over 20 years by being careless and sending any vaccine that we do not trust.
Thank you very much, Tabani. You've answered that, really, really adequately. I mean, I hear what you say also about the opportunity here, and there's a thought in me sometimes that thinks in some of the more, you know, hard to reach communities, as we go ahead with the COVID vaccinations, perhaps we should start lining people up, and there should be just a mass vaccination campaign in places where we have lagged behind. But that's a whole nother conversation. I mean, in addition to COVID, using the sort of piggybacking on the existing infrastructure that's going in for COVID to ensure that, you know, children, maybe those who are not being given COVID vaccines, etc., are also being dealt with. But that goes to a whole conversation around vaccine delivery and the cost of logistics and delivery, which we invited you to speak about last week, but you couldn't come. I shall talk to you about that one later. But I'm going to pick up on what you said and actually jump over to Maysoon at the because you talked about affordability and accessibility and how that affects uptake. And I just want just a little word from you, Maysoon, about that whole trust issue, about, you know, are vaccines okay? You've said a bit about it already, but can you reassure our listeners even further?
Sure. Well, as you mentioned, affordability and accessibility are also key components of vaccine hesitancy. These are considered the physical barriers, if we may say, that many communities and individuals face on a daily basis. As vaccine manufacturers, we work with many stakeholders to do all what we can to ensure that routine vaccines are available at affordable prices through UNICEF and Gavi, for example. Specifically talking about the COVID-19 vaccines, as an industry, we pledged to ensure that the vaccines would be available to everyone, everywhere, because as you know, it was mentioned many times, and as you mentioned, the WHO has stated on many occasions that no one will be safe from the virus until we all are. And we took this very seriously. And that's why the pharmaceutical industry was a founding member of the ACT Accelerator and COVAX. And this collaboration is what I also spoke about before. This unprecedented collaboration is allowed for the first deliveries of vaccines to be available in many countries as well as Africa. Specifically talking about us in MSD, we're committed to working with governments and others to make treatments broadly accessible and affordable for the people who actually need them. And while affordability and accessibility remain to be concerns, but again, it goes back, I would say, to putting vaccine confidence and hesitancy at the center. When discussing all these issues about affordability and accessibility, we still need to address vaccine hesitancy and make hesitancy at the center of all our discussions, because it's important to make safe and effective vaccines available, but it's most important to ensure they get into people's arms.
Ports to arms, arms, everybody. Thanks, Maysoon. I'm going to address very quickly something that's in the chat, and I'm conscious that I can't believe where the time has gone. You know, they say time, you know, what races along when you're having fun. We only have about 7 minutes left, so I'm going to ask the remaining people to speak very briefly, but also I want to take into account what's going on in the chat. So Rodriguez Casando, who's from DRC, is just saying that they're taking into account the fact that there are very few cases of COVID-19 in Africa. Don't we think an African response should be integrated into a global response against COVID to engage populations effectively? I just want to address that very quickly and say that that is a very dangerous narrative. It is not that there's few cases of COVID-19 in Africa, it's that we don't know what the cases in Africa look like. There is as far as COVID-19 cases in Africa, we are flying blind. There are no diagnostics. I spoke about this on Christian Amanpour the other night. There are no diagnostics in most of our Africa, or limited diagnostics in most of our African countries. We have kept, we have stayed under the radar. Had this pandemic started in Africa, we would have seen a whole lot more investment into diagnostics on the continent, because the whole world would have been determined that it did not escape our shores and come and affect them. But because it started outside Africa, the diagnostics capacity in Africa is limited. I am sitting in Abuja in Nigeria, and I can tell you that it costs almost $200 to have a COVID test. I cry every time I have to do a COVID test. And I am one of the very, very, very few, the 1% of the 1% that can afford, quote unquote, to do that. So imagine people in rural areas. Imagine countries where there are very few tests. There's also recently been a study where we've just learned from Nigeria, a seroprevalence study with CDC and the US and others, where we now see that there's over 4 million people in Lagos alone, Lagos, Nigeria, are showing that they have actually had COVID. So that is a dangerous narrative and we must move away from it. Why do I say that? We still don't understand this disease fully. We don't know what the long-term effects are going to be. We don't know what the long-term disease morbidity burden is going to be on our governments. So to say now that we have escaped COVID, no. And that the other thing with that is also affecting vaccine hesitancy. Why? Because if people don't believe that COVID is affecting Africa, then why should I take a vaccine? So we need to be very, very careful with that narrative. I'm seeing some conversation here about Tanzania. I don't even want to get into the political and the drama of various countries and COVID or no COVID, but to say that the main concern for me with that is the issue that political will and political commitment is so critical to the health of our populations around the world. I cannot say it enough. And that we all need to choose our leaders carefully, because who you choose as leaders will determine whether your mother, your grandfather, your sisters, or your brother lives or dies. That is all I have to say on that particular issue. Moving very quickly on, because Lolam has told me that we're losing time. I'm going to go very quickly to Taj and just get a couple of last comments from you on how do you think we should communicate the proposition of prioritization of groups in the vaccine rollout process? Because since we don't have many vaccines, and I mean, Tabani, I'll take this offline with you later. We also know that it's highly unlikely we're going to be getting many more doses in the near future because of production concerns. Taj, over to you.
Thank you, Madam Chair. So in terms of prioritization, one thing Africa CDC has done was to convey a very high-level meeting to discuss this issue of fair allocation and prioritization of vaccines, sometimes last year with MRC South Africa. Now, in terms of how do we approach this, I think for Africa CDC, we know that yes, this vaccine is not going to come all at once. It's going to trickle in, and from our projection, we know that from COVAX we're going to get something close to 700 million, and of course it started trickling in. We know that from MTN, we're also going to get some vaccines from MTN. From Harvard, 270 million is already secured one way or the other. A lot of discussion is ongoing. So in terms of trying to cover the 60% or so of our population, I think on paper, we have that clearly mapped out. Now, to discuss with our community, I think it all boils down to the issue of community engagement that we've been talking about since we started this session. And from the survey that we did, we now know which voices are the trusted voices as far as the community is concerned. We also know that what sources are the trusted source of information as far as the community is concerned. We have also been able to understand how do we locally contextualize the different modalities of passing this information through which medium. So it's a combination of a lot of things. So using the appropriate voices, through appropriate medium, I think we should be able to let the community know that, look, for the first set of vaccine that will come in, we need to prioritize this group. And for now, we know that our healthcare workers, our vulnerable populations in terms of those elderly people, those with underlying chronic disease conditions need to go first. And of course, the second group, we should be looking at those services that will allow us to safely reopen our economy also need to come in, you know. And the key thing we need to emphasize in our communication is the fact that people need to wait for their turn. I like the way Tabani said it that, yes, I'm not yet vaccinated, although the vaccine is in Geneva because I'm still young, you know, and I know that my turn will come, maybe sometimes October.
That's not what he said. He didn't say he was young. I'm the young one here.
No, he said from his age. He said from his age, he knows that You know, so I think the emphasis here is that for people to know that they need to wait for their turn, you know, and for us to also let them know the reason why they need to wait for their turn, the reason why certain group need to go first before others. So I will stop there and hand over back to you, Madam Chair.
Thank you very much, Taj. I'm going to go very quickly to Joy. We're literally out of time. They've given me an extra 5 minutes because they say we're all being so exciting and so engaging. So if you all don't mind staying on just a couple of minutes more. Joy, I'm going to go over to you and ask you about primary care physicians and the role that you have in building public trust, and just, yeah, what is the role of primary care providers, and how do you support them to advocate for vaccine acceptance? Thank you, Dr. Joy.
Thank you very much, Chair. Basically, the role of the primary healthcare provider is to be a community cohesion person, a person who brings in the community together. You are basically extremely at the community level, you're trusted, and being the trusted person, you need to have the information at hand. You need to be well informed with evidence-based medicine and look for real facts, not infodemia, and ensure that you're sharing this with the community in order to strengthen the uptake of the vaccines. Just as Raj has said, the vaccine may not reach everyone at the same time. And so as primary healthcare practitioners, it's our role to prepare the people we see, the people we are offering preventive and promotive services, so that they get to know what to be doing in order to protect themselves and prevent themselves from getting the infection. So the government has a role also to ensure that primary healthcare providers do get the information timely and adequate in order for them to share it in the right manner within communities. And before I close, collaboration with not just stakeholders, with colleagues all over globally, because information has to be shared. If we don't collaborate, we'll perish. So we really need to collaborate, not just in terms of research, but also in patient care and vaccine uptake. Thanks a lot.
Thank you. Thank you very much, Dr. Joy. Thank you. Collaboration, I love that word. We need to collaborate, we need to build coalitions. And I'm going to start to close this incredible session that literally has just flown by summarizing for me a couple of the key points. Yes, vaccine hesitancy is real, but also so is the issue of vaccine equity. We cannot vaccinate people if we don't actually get vaccines. We need to get vaccines into countries, but again, as Tabani said, we need to make sure that they don't rot away in Mombasa port or whichever other port there is. And so we need to get vaccines from ports to arms. Getting vaccines from ports to arms will require all of us working together in coalition, collaboratively, also with people from outside of Africa. But most important, this is an African moment. This is an African moment, and I like what was said earlier, that this is a proud moment for Africa. You know, yesterday again, I was, as I said, this interview I did with on CNN, you know, I said that what we've done as Africans in this moment is that there was a table that we were not given a seat at. And so, you know, a few of us who maybe work with Gavi or what have you, maybe are sitting on the Gavi part of the table. But for us as Africans, we didn't have a real seat at the table. So what did we do? We pulled up a chair. They said, you can't sit down. So we got on the table and we said, you know what, we are going to take this show and we are going to begin to deliver our own PPE, and we're going to begin to search for our own vaccines. And we need to do the same thing when it comes to the working all the way down to the community level. We need to learn, as Tabani said, not to waste this crisis and to recognize the urgency of now in this moment. The urgency of now means we have to get vaccines onto the continent. The urgency of now means that we have to work together as a people to ensure that the vaccines get to the very last mile. The urgency of now means that we have to push down that thing within us that says, I'm an oga at the top, I'm a big boss, and therefore I'm going to get my vaccine first, even though I'm only 35 years old, and wait my turn until it is my turn to get the vaccine. But also we cannot forget the manufacturing dilemma so that we plan for the future. We need to work with our partners, you know, the MSDs of this world, the different organizations and pharma companies and others, to see how they can support us in this moment of crisis when all eyes are on us. As we're talking vaccines, we're also talking manufacturing. And we all need to begin to work to the community level, our healthcare workers, our primary healthcare workers, our community healthcare workers. We need to make sure everybody is trained in this moment. Vaccine hesitancy is real, and infodemic is where I'm going to end. We all have a role. If somebody sends you something that is wrong, it is important that we go back and we say, no, this is not true, that we explain the work that has been done, the hard work that has been done by the scientific community, the global community, to say that these vaccines are safe, that they're not going to cause anything in you, because it's happening now. I think the advantage we have is that it is rolled out all over the world so people can see. And so to that, I want to thank my panelists. I want to thank each and every one of you for the experience you brought to the table. I want to thank, you know, Maysoon, thank you for giving us your vaccine experience from where you're sitting in the United Arab Emirates. Those of us who are from Geneva, Tabani, those of us who are in Africa who have not yet seen vaccines, I pray that one day soon they will come to your shores and that you will get them in your arms. In the meantime, we're all working hard to ensure that this world is a safer place. And it has been my privilege and my honor to be here with you all today. And it is over and out. I will stay in touch, all of you. Take care. Thank you. Bye.
Bye-bye.
Have you taken everybody else out? Can we talk now?
Yeah.